I'll overview PA rehabilitation. Pulmonary artery stenosis is observed in native pulmonary arteries, such as the case of syndrome like this, and also observed in the postoperatively, VT shunt, unifocalization, bending, or PA plasty. The usual indication of intervention is if the pressure gradient more than 25 and the RV aorta pressure ratio is more than 0.6 and lung perfusion scan shows a more than 2-to-1 distribution. It's a usual indication. And the basic principle of pulmonary rehabilitation is like this. Postnatally, pulmonary vessels continue increase in number, size, and length, continue until 8 years of age. Growth of distal small vessels depends on flow to the distal parenchyma. So the goal of pulmonary rehabilitation is to optimize flow to the distal branches. The stenotic pulmonary vessel could be enlarged by a balloon dilatation or stenting. Therefore, aggressive rehabilitation as early as possible in order to optimize flow for normal growth by repeated interventional procedure. I would like to point out two important things in intervention in pulmonary stenosis. First one is imaging of pulmonary stenosis for selection, measure, and intervention. And the second important thing is secure wire positioning. The pulmonary stenosis is usually multiple, so we usually perform first from the distal one and the severe one first, and then proximal one and the less severe one next. So it's a very time-consuming procedure. Therefore, we need a staged intervention. Regarding a balloon angioplasty, balloon size and burst pressure is important, especially for the native pulmonary arteries. The risk of aneurysm or rupture is high. For the resistant stenotic region, cutting or scoring balloon can be used. Regarding a stent, the distal branch or bifurcated region stenting is an issue, and stenting in infancy is also an issue. So these kind of issues will be discussed in next case presentation. This is one example of a pulmonary rehabilitation, courtesy of Dr. Goldstein in Pittsburgh, published in JACC. This is a patient pulmonary atresia, unifocalized right pulmonary artery, but as you can see, proximal RPA was very diffuse hypoplasia, and the segmental artery is also very small. So multiple staged ballooning slightly enlarged the distal vessel, and the proximal stenting or more enlarged the distal pulmonary vessel. However, right upper pulmonary is a very diffuse stenotic, and kissing stent like this enlarged the right upper pulmonary artery, and the further dilation with the simultaneous double balloon technique was used. So finally, we can have this kind of good pulmonary rehabilitation compared to the panel A. Sometimes we encounter the one artery occlusion. Then we should perform a pulmonary vein wedge angiography to find out the native pulmonary artery. And using a CTO wire and the balloon, we can recanalize the vessel like this. So it's a good example of pulmonary rehabilitation. For the good rehabilitation, the imaging is very important, so I'd like to introduce 3D rotational angiography and vessel navigator. First one is rotational angiography. This is a patient pulmonary atresia VSD MAPCA. After unifocalization, as you can see, the right pulmonary artery course is long, tortuous, and you can see the stenotic lesion over there. It's a unifocalized portion. So I performed balloon angioplasty, but unfortunately dissection occurred. So I plan to implant the stent over there. The successfully implanted the stent. However, the stent compressed the one segmental artery proximal portion. So later, I perform rotational angiography. We can see the proximal stenosis of one segmental artery. And I made a 3D reconstruction image and put it onto the fluoroscopy for the road map. So I can easily select that branch and successfully perform the balloon angioplasty like this. This is patient Williams syndrome who showed the multiple pulmonary artery stenosis and left pulmonary artery rotational angiography. We can see the 2 severe stenosis on the branch pulmonary artery. After 3D reconstruction, I rotated until I find out the best angle for the intervention. So a little bit RAO and a little bit caudal view is the best angle for the intervention. So I put it onto the fluoroscopy and perform a balloon angioplasty, measure and perform successfully. In the same patient, the right pulmonary artery rotational angiography shows more than 5 portion stenosis. So with one angio, I can select all the side branch and successfully balloon dilatation like this. So initially, the right pulmonary artery like this and left pulmonary very stenotic, and on the low column, you can see the well-rehabilitated right pulmonary artery and the left pulmonary artery like this. 5 times cardiac catheterization is needed for this kind of rehabilitation. Next imaging is vessel navigator. Vessel navigator is a fusion imaging of CT and the fluoroscopy. Using a CT, I made this 3D reconstruction image, and also I can rotate it any angle to find out the stenotic portion well and which angle is the best angle for the intervention. This is an example, pulmonary atresia VSD PDA. The both pulmonary artery size is a little bit small. Surgeon performed the complete repair in the neonatal period using a 8 mm fresh orthopedic cardiac roll. However, in 5 months, as you can see, the distal conduit is stenosis and RPL diffuse hyperplasia. So we need another intervention, but balloon may not be work well. So we plan to put a stent over there using vessel navigator. I selected the right pulmonary artery easily and put a stent from the MPA to the right pulmonary artery successfully. The angio shows the markedly enlarged right pulmonary artery and the MPA. However, it jailed the left pulmonary artery. So I select the left pulmonary artery and the balloon dilatation to make a hole to the left pulmonary artery. So we can use these 2 imaging modalities to make a 3D reconstruction image as a roadmap. However, I prefer to use using a vessel navigator because it has less radiation and more accurate imaging. Compared to the 3D rotational imaging, vessel navigator is a more accurate imaging. Okay, I'd like to move on to the pulmonary breast MAPCAS. The treatment option is divided. One group, primary repair, it means the unification and the breast closure, and the other group is stage 1, combined catheter surgery approach. Primary repair is usually performed by a Frank Henry group. He performed the 1-stage unification and complete repair if the MAPCA is good enough and no stenosis. However, MAPCA is small or rare, or if there is a multiple stenosis, he preferred to choose a staged reconstruction. Their result is excellent. However, the problem is that this kind of a good result can be obtained only by Frank Henry. This report from the Melbourne, Australia, about the pulmonary atresia MAPCA, among the 60 unifocalized MAPCAs, 26 thrombosed and 12 showed severe stenosis. It's a retrospective study. So after then, they learned and realized the size and compliance of the native pulmonary artery is very important for the long term, and unifocalizing procedure may compromise the growth of the pulmonary artery. So their strategy has been changed like this. Their new strategy is CT or selective angio in 1 week after the birth, and the central shunt in the neonatal period, and the follow-up CT, MRI, or cardiac cath in 3 to 4 months, and RB2PA condu performed, and later complete repair, changing a conduit and VSD closure. This is new. And in this report from the Boston Children's Hospital in 1993 in Circulation, the new concept, combined catheter surgery approach, because interventional procedure could be performed at that time. So in stage 1, cardiac cath to figure out the pulmonary artery bed supply, and stage 2, RB2PA condu. In the stage 3, catheter again to dilate the pulmonary artery and embolize the MAPCAS. In the stage 4, condu change, VSD closure, total repair. So their result is the stage group is best compared to the primary repair at that time. I'd like to show you my case, 2 cases. First case is a 50 days old boy, diagnosed as pulmonary artery with MAPCA, CT checked, and we can observe some MAPCAs, not from the descending aorta, from the aberrant right subclavian in the back. It's the right aberrant right subclavian artery, and from this one there is several MAPCAs arising. In this above view, we can observe the confront pulmonary artery is small. So we draw aberrant right subclavian artery, MAPCA 1, 2, 3, 4, like this. And I confirm it by angio. Descending aortogram shows the aberrant right subclavian artery, and there is several MAPCA. I select one by one. This one to the right upper lung, this one to the left lung, not this one is right lower lung, not connected to the confront pulmonary artery, and the last one to the right lung, and it connected to the confront pulmonary artery. The confront pulmonary artery size is very small, but as you can see, the total contrast amount is only 7 millimeter in 5 angiogram. I used the contrast saline injection method, so it's a good way to reduce the contrast amount in MAPCA study. Next case is the pulmonary vs MAPCA, small confront pulmonary artery and MAPCAs. So first, because of this small confront pulmonary artery connected to the aorta central shunt, little bit grow. After then, RB2 conduit was performed. Distal pulmonary artery little bit grow, and performing a balloon dilatation several times. And in 2005, the confront is small, and in 9 years later, we can have this big, huge pulmonary artery. So the pulmonary artery rehabilitation is successful with the multiple stages procedure. So in conclusion, aggressive repeated interventional procedure as early as possible is crucial for PA rehabilitation. We can use the 3D rotational angiography or vessel navigator for the imaging. I prefer to use the vessel navigator because of this advantage. Regarding a pulmonary breast MAPCAs, we should try to find out the confront pulmonary artery by a selective angiography or a pulmonary vein-wedge angiography. Establishment of early RB2PA continuity with subsequent PA dilatation and collateral embolization is important. And most important thing is collaboration regarding decision and management steps between surgeon and interventional cardiologist will eventually allow successful repair in the large majority of patients with APCIS. Thank you for your attention.